Okay, so this is the conversation, and I'm going to do a series of these, AJ. I'm going to talk about osteoporosis and all kinds of different topics because I love seeing patients, and I don't have the luxury of sitting down with every woman who has a problem or every man who has a problem. So I'd like to make a series of videos with you about what I would like to tell a patient who had breast cancer. And I think every doctor should be sharing this basic information with a patient so that she, in this case, breast cancer is 100 times more common in women than it is in men. She, in this case, can make informed decisions and avoid harmful treatments and unnecessary worry and unnecessary guilt. Tremendous amount of guilt associated around this disease. And there's a lot of emotion and a lot of lawsuits. The number one reason doctors are sued is failure to diagnose breast cancer. So your doctor's scared to death. Your doctor has the hesitancy to tell you what everybody else is saying, to get with the crowd, whether it's true or not. So what causes breast cancer? Well, probably environmental chemicals. Yeah, pollutants. I had a patient one time who's told me she had breast cancer. She says, my two sisters have breast cancer too, and we live downwind from a factory. Yeah, I think the initiator and subsequent promotion of breast cancer are these various chemicals. And some of them are involved with estrogen, and we're going to talk a lot about estrogen. Now, it's just not the chemicals spewing out in the air into the soil that your crops are growing in. It has to do a lot with what you decide to eat. These chemicals lie on your vegetable foods in low concentrations. As they move up the food chain, which is in your bottom left-hand corner, what you see is something called bioaccumulation happening. And the result is biomagnification of these chemicals. So maybe you start out with 1 part per million on the grasses and grains and seaweeds and so on. And as you move up the food chain, say to the cow or the pig or the fish, because these are fat-soluble chemicals, they get collected in body fat. What happens is you may increase the concentration 1,000-fold. And of course, the end of the food chain is that baby sucking off mother's breasts. And I've told you before that the Environmental Defense Fund did a study in 1978 where they looked at the breast milk of 1,400 women in 48 states and declared it a health hazard. The milk of Inuit Eskimos, by the way, the women, their breast milk is so toxic, it's been declared necessary to bury it in toxic waste dumps because of the environmental chemicals. This is a big deal. Okay, so, the chemicals are there, they're all around the world. The best way to avoid them, of course, is to stay away from pollutants the best you can see. And also to eat low on the food chain, eat potatoes and, rice and corn, not the animals. That's how you get into trouble. What you eat affects your hormone levels, and breast cancer is a hormone-dependent disease. Estrogen promotes breast cancer growth. Deprivation of estrogen causes women to live longer. And the effect of your diet causes your estrogen levels, and we talked about this last month, causes your estrogen levels to increase as you eat the high-fat American diet. In fact, they're 50% higher. Now, the consequence is overstimulation of your breasts, ovaries, uterus throughout your reproductive life. But you also start your reproductive life earlier. Little girls are supposed to be thinking about babies and families when they're 16, 17, 18 years old. They develop sexual characteristics and reproductive abilities when they're 8, 9, and 10 years old. Same thing with little boys, similar with little boys. And at the end of life, menopause comes later for those who eat a high-fat Western diet. And we know that early menarche and late menopause are associated with a dramatic risk in the chance of getting breast cancer and dying of breast cancer. So you want to focus on your estrogen levels. Some of those chemicals I showed you in the last slide are called estrogen disruptors, and they affect your hormones in tremendous ways. And anyway, there's a whole discussion of this, and this particular graph is out of a book that I published in 1985 called A Challenging Second Opinion, and you can get that book free from our website, as well as I think the McDougall Program for Women we're now offering too free. There's no gimmicks. Just go to the website, download it, and you can read it. I wrote that in 1985, and I don't have to remove or change a single word. Nor do I really have to update much. As we talked about, I got it right the first time, and the truth don't change. So it's very important that you understand the following mechanisms involved with breast cancer. It has to do with the growth of cancer cells. And for the rest of our discussion, you must understand this, because if you understand it, then everything I tell you will make sense. What happens is the breast tissue, and we could talk about prostate and tell the same story in men. The breast tissue gets damaged by these chemicals. Now, most of the damage is so severe that the cells die. But sometimes the cells aren't injured bad enough to die, but they're injured bad enough to become unneighborly. And they start doubling at their own free will. Now, cells are not allowed to double at their own free will, except under certain circumstances, or aren't allowed to double, period, except in certain circumstances, such as when a child grows, the cells are allowed to double. And if you injure yourself, the wounds, the cells proximal to the wounds are allowed to divide and close up the wound. Otherwise, the cells are not allowed to divide. But what happens is they get injured and they lose this tendency to have a normal growth pattern. They start dividing at their own free will, not like wildfire. It's been determined that the average doubling time for a cell, a cancer cell, is every 100 days. Okay, so you get the first cancer cell, and always one cell leads the way. A breast contains 100 billion cells per breast. A prostate, 100 billion cells also. So one cell out of 100 billion cells stops obeying the rules and starts dividing at its own free will. 3.5 months later, 100 days, it becomes 2 cells amongst 100 billion cells. The divisions continue, 8, 12. You've had a cancer for a year. And you have, somewhere around 12 cells lurking in a breast that contains 100 billion cells. You can't find it. And the divisions continue, doubling, 32, 64. You've had cancer for 2 years. You've got a mass that contains about 100 cells. Nobody could find that. There's no technology that could discover these cells. You could set loose a team of pathologists looking at your amputated breast. They would not be able to find these cells. All right, the divisions continue. And by the way, it's early in the disease that the cells break loose and go through the venous system and travel to other parts of the body. It's called metastasis. So they break loose from the tumor in the breast. They go to the liver, lungs, brain, bones, and they double at a similar time to the original cell. So here we are at 2 years. Let's take you up to there. We got 100 cells. The divisions continue. And finally, you've had cancer for 6 years. You've got a tumor mass the size of a lead tip of a pencil, the size of a period on a paper. It consists of 1 million cells. It's not detectable by any technology available. And yet you've had cancer for 6 years, and if it's truly cancer, and a lot of what is diagnosed as cancer really isn't life-threatening. But let's just say it's truly cancer. Then before you can detect it, it has gone through 10 years of division. You've had cancer for 10 years. It's 1 billion cells. The tumor mass is the size of an eraser of a pencil. It's 1 centimeter in size. Then you can find it. Then you can feel it on a breast. Then you can detect it by a blood test for prostatic specific antigen. It's got to be 1 centimeter in size before it's detectable. Now, I want to point out something too. When it comes to tumors that are detected early, they're usually detected by women who examine their breasts, and we're going to talk about that. They're found by the woman herself. But slow-growing tumors are generally found by mammograms. On average, a tumor found by a mammogram has been dividing for 14 to 17 years. Okay, so what you understand is that before you even know that you're sick, the disease has already determined its course. It's already spread throughout the rest of the body. The cattle are already out of the barn before you shut the door. There's a very positive side to this message too, so just hold on with me. If you understand this mechanism, you understand why treatments don't work, and you understand why early detection is a misnomer. By the time a tumor is found, 2/3 of the course of the tumor has already occurred unbeknownst to the patient or the physician. You're just dealing with the last third of the disease. I published this many years ago in 1985. You see the chart I put together, and it shows the development of a tumor over a period of 13 years. You've got to understand this. It takes a long time. It's not like wildfire. It may appear like wildfire to you because you're only looking at the last third of the disease. You're only looking at a tremendous amount of spread that occurred long before you or your physician were aware you were sick. All right, I'll assume you understand this, and I will move on to tell you not all hope is lost. I told you I published the first study on the dietary treatment of breast cancer back in 1984. And that study is available for you to look at. It's somewhere on my website. It was many years later that the American Cancer Society finally came around to repeating my work and my conclusions. And they did so February 13th, 2015. The American Cancer Society now recommends that a part of the fundamental therapy of a person with cancer, including breast, prostate, colon, melanoma, is to change their diet toward the kind of diet that you and I believe is so important. This is law. This is the American Cancer Society. This is what every physician should be looking at. And what happens is you change the rate of doubling. I told you the average doubling time is every 100 days, every 3.5 months. Well, some tumors double every 23 days. That's not good. And other tumors double every, 800 days. That's good. I mean, my goal is to have every one of my breast cancer patients live as long and as high a quality life as possible. So, a woman destined to die in 3 years, maybe we could squeak 12 years out of her by not throwing gasoline on the fire, by not promoting the disease. And a woman who's destined, to live 12 years, maybe she'll appreciate her 107th birthday. I think that's real. You could change the course of this disease. You could change the doubling times. And if you wanted to get more details on this, you can go to my February 2015 newsletter. All right, let's talk mammograms and guilt. If you find out you have breast cancer, one of the first thoughts that comes to a woman's mind is, oh, I should have found it earlier. I just told you, early is 14 to 17 years after the cancer starts with mammography. But you feel guilty. You're sure it was your fault, and too often doctors do nothing to make you feel better. Let's talk about mammograms. You know what the procedure is. It's where they squeeze your breast, take some x-rays. It's a crude procedure, by the way. It was, when I was a medical student, it was first introduced by Wolf. I saw some of the first mammograms ever done, and we thought they were pretty crude then. They haven't changed much. They're still crude. And what they do is the jaws of this machine squeeze your breast, and about 1/3 of the women say they'll never have this done again. If you happen to have a positive finding on a mammogram and later on, you're told that it was a false positive, everything's okay. Half the women still worry about being sick 3 to 6 months after being reassured that they don't have cancer. It does a tremendous amount of destruction. How much good does it do? Well, let's take a look at the Cochrane collaboration. Cochrane collaboration is a supposedly unbiased group of scientists and interested citizens. They're in well over 100 countries around the world, 40,000 volunteers. And they write papers that help me as a doctor understand what the science says. I read a lot. I enjoy the scientific literature, but I don't have time to really read everything. And so they take experts in various fields, all the way from treating head lice to treating breast cancer, and they review the scientific literature and come to conclusions. That's the Cochrane collaboration, and they publish papers in the Cochrane Library. You can believe these papers. Almost all of them I agree with. The head of the Cochrane collaboration was Peter Gertzke. He's a friend of mine. And he served for 23 years as the head of the Cochrane collaboration. He published a book called Mammography, Screening, Truth, Lies, and Controversies. You can get this book on Amazon. I encourage you to get it if you need to convince a knowledgeable friend, physician, etc., about your position on mammograms. As far as a good read, it's not a good read. I mean, I asked Peter one time if he wrote his own books, and he said, yeah. And I should have told him, well, I can believe it. Because, they're really, really technical, really difficult to get through. But, I lived this research. So to me, it was very interesting and very relevant. So you might want to get this book. A doctor insists that you have a mammogram. You say, read this, and then you tell me I need a mammogram. Anyway, the conclusion of the Cochrane collaboration is routine mammograms, every couple of years, do not save lives. And they increase the number of women overdiagnosed. Overdiagnosed is a big problem. And they increase the number of women who are having mastectomies. After all, if you go look for a problem, you find it, and of course you have to treat it then, right? Well, they put out a brochure in 2012 that was in 13 different languages, which told women not to have mammograms. And this is what the Cochrane review says. It says that if 2,000 women are screened regularly for 10 years, one will benefit from not dying. 1 out of 2,000. And of course, if you're that 1 out of 2,000, you go, whoa, it's worth it. But we got to talk about everybody who goes through this. At the same time, 10 and as many as 50 healthy women become cancer patients and will be treated unnecessarily. They're overdiagnosed. They would have never died of their cancer. It was either too slow growing or a false diagnosis. So you have made 10 to 50 women breast cancer victims. And no longer do they say, hi, Marge. They look at you, oh, breast cancer. What you doing today, Marge? You can't get health insurance. You can't get life insurance. You live under this cloud of thinking you're going to die. Oh, and if I'd only gotten the mammogram earlier, I'd have been okay, right? Guilt. And if you do 2,000 mammograms, somewhere between 200 and 600 women will be required to go through further testing and treatment. Yeah. And their conclusion is it's therefore no longer seems reasonable to attend for breast cancer screening. Okay, does your doctor know this? No, your doctor doesn't know this. Let me explain this to you. Of course, when I say this, you know that I'm generalizing. There's some doctors who are well informed and really stand by their patients, but most of my colleagues are practicing medicine based upon incorrect information, and they don't take the trouble to find out what the correct information is. Let's take a look at a study that was published, and there are 2 studies that were done. The other one's showing the same thing. They wanted to find out what the physician's knowledge was concerning mammograms. What do they think about them? And so they went and looked. They went and talked to general doctors, family practice doctors, internists, et cetera. And they asked them, what do you think the benefit of a mammogram is? And they said, improve survival. Okay, they said, you'll live longer from the time of diagnosis, improve survival. And they also said, you'll find more breast cancers, and that's good for a patient. But the truth is that few of the doctors recognized that only randomized controlled trials showing an improvement in survival for the screen group is evidence that it works. Let me go through this in a little detail with you. Okay, finding the tumor early. Here's the day of death. It's listed there as a 0. If you're not doing screening and you just casually do examinations, you may find the tumor when it's a little larger, say 3 years before diagnosis. If you're going through extensive breast examinations, checking your breasts every hour, every day, doing mammograms, et cetera, and you find it, say, 7 years before you died. Yes, you lived longer from the day of diagnosis, but you didn't live any longer, period. You just lived longer knowing you were sick. You just lived longer knowing that, being a customer of the medical business. You died the same day. Early detection just finds the tumors earlier. But that's true because of the mechanism I just explained to you. By the time a tumor is found, it's 10 years old. Or by mammogram, it's 14 to 17 years it's been growing. Okay, so early detection is a fallacy. It just means you found the disease earlier, that's all. Oh, and by the way, they used to say that if you lived 5 years, you were cured. Well, you can see what nonsense that particular message is. The other thing that doctors said is you find more tumors, that's good. You increase detection. Well, if you look for tumors while you're still alive and you find a whole bunch of tumors, and what happens is you take these tumors out, and that's all interesting. But if you compare the tumors of a woman who didn't go through this type of examination, in other words, she didn't do early detection, she didn't have a whole bunch of biopsies done, and you add the tumors up, you find out that they're the same number of tumors in a woman who didn't have early detection, and those women who found tumors earlier, in other words, they found tumors while the patient was alive. Doesn't change the day of death. As they said in this, the only way that you can really establish whether or not these early detection techniques work, and I'll tell you, as far as I know, and I'm pretty up to date on this, there are no early detection methods that result in improvement in survival. Okay? So here you take let's just test mammography breast cancer. Here you take a large number of women, you divide them into 2 groups. One you do a whole bunch of mammograms on, the other you don't. The ones you do the screening on, you ought to, at the end of period of time study, you ought to be finding more women alive, and you don't. These are called randomized clinical trials. And they all show the same thing. Early detection for all the cancers I'm aware of does not improve survival. Well, there are a couple of minor exceptions, but certainly all large tumors. Breast self-examination is harmful. Don't do it. That's me talking to you. No, that's not me talking to you. That's the Canadian Task Force on Preventative Health Care. In 2001, they told Canadian citizens, don't touch your breasts. The American Cancer Society finally came around with the U.S. Preventative Services Task Force statements. And they said they shouldn't be teaching, doctors should not be teaching women to do breast self-examinations. Why? Well, because you find problems. And the result is you go for tests and treatments that hurt you. Right there, but found evidence of increased harm from benign biopsies. You better be sure that you're looking for something that you can change, you can make a difference in, and you can't. And if you understood the natural history of cancer, of breast cancer, then you understand why this has to be so. So how do you find a suspicious mass? How about when you take a shower? I mean, that could be once a week or once a month. That's good enough. How about when you take a shower? Rather than fixating your whole life on checking your breasts and being afraid and having guilt, which is what happens with women. They feel this obligation to make sure that they catch it early enough, and they can't. So what are you looking for? Well, cancers, they're usually hard and irregular, and they're fixated to surrounding tissues. A lump, like a fibrocyst or a fibroadenoma, they're usually smooth, and easy to move and sometimes painful. But you only make the diagnosis of cancer under the microscope by an experienced pathologist. So that's the amount of effort you should be put into early detection. When you take a shower, don't ruin your life over it. All right, so if you find a lump and say it's cancer, and again, this is discussed in a book that's available for you for free, no gimmicks, along with the McDougall Program for Women. I believe Heather put that up. Written in 1985, good grief. Well, the truth don't change. Anyway, you can have a biopsy. You can have a lumpectomy. You can have a segmental mastectomy. We're increasing the amount of good tissue that's taken. You can have a simple mastectomy, removal of the entire breast. But when I first started practicing medicine back in the early 70s, 1980s, the standard treatment was a radical mastectomy. They took the breast, the lymph nodes on the affected side, and the muscles on the chest wall, mutilating. Destroyed women's personal appearance and their lives. Anyway. So the difference being a lumpectomy, you just take the lump out, all right? And it can be relatively non-deforming. It's important that you get clear margins. And that can be determined at the time of surgery. The doctor makes sure that he or she got all the tumor and there wasn't residual left in the breast. Not that it will reduce your chances or increase your chances of dying if it leaves a little bit of extra tumor in the breast. It just becomes another problem we'll talk about in a second. So you do a lumpectomy, and the argument is that if you just do a lumpectomy, that you'll have an increased risk of local recurrence. Well, not if you do a lumpectomy with clear margins, you don't. And so without the criterion that you have clear margins. I mean, just looking at random lumpectomies, the chance of the tumor recurring in the breast is about 30 to 40%. The chance of it recurring on the chest wall after a mastectomy is about 10%. And if you add radiation, the chance of the tumor occurring on the chest wall is again about 10%. Okay. What we're talking about is local disease, controlling local disease. And if you remember the discussion we had at the beginning of this, you realize that we're not dealing with just local disease. We're dealing with systemic disease. In other words, disease that's spread throughout the rest of the body. A mastectomy, they take the tumor, the breast, as I told you, are radical. They take the muscles underneath and the lymph nodes. All right. Bernard Fisher, one of my heroes. He did the most important studies on breast cancer that have ever done or ever will be done. They did a study back in the 1970s, finished in the 1980s, on comparisons of various kinds of surgical treatments. And I want you to notice that the things that they looked at were total mastectomy, lumpectomy, and lumpectomy plus radiation. Please take a look at this in the bottom left-hand corner. And what you see is there's no difference in survival among the treatment groups. Do you see that? We've known that for 45 years. Okay, so let's go over this one more time. The chances of surviving are the same if you have the entire breast removed, including the muscles and the lymph nodes, compared to just taking the lump out, no radiation. We're not talking about any radiation added, and taking the lump out and adding radiation. All right, the effective radiation after mastectomy and axillary surgery, 10-year recurrence and 20-year breast cancer mortality. After 20 years, radiotherapy was not associated with improved overall survival. If you want to read, the various studies, if you go to my September 2017 newsletter, there's a thorough discussion about the effects of radiotherapy. And again, if you recall the natural history I gave you of this disease, why would radiating the chest wall cause you to live longer? The tumor is already in every part of the body. Doesn't make sense. Why would more extensive surgery make a difference? And when you die, it makes no sense if you understand the natural history. You don't want to leave a breast cancer untreated. I've seen about 8 women in my career who have decided not to have the tumor removed. And I have evidence that says they would live longer than women who had the tumor removed. It certainly doesn't shorten your lifespan by leaving the tumor. It's just an ugly mess. You know, it's like taking care of a piece of hamburger on your chest wall. Why put a woman through that? So you need to control local disease. And that's why I recommend a lumpectomy with margins free of cancer cells. That's my treatment of choice. It's been my treatment of choice for half a century. It used to be the treatment of choice at Cleveland Clinic. Barney Cryle used to be a strong advocate of just doing lumpectomies. So you want to make sure that you don't have this kind of an outcome. And not that it'll affect the day you die, but it'll affect your life significantly. And radiation can be delivered, or more surgery can be had if the tumor comes back and you get the same results as far as how long you're going to live. You know, in other words, the radiotherapists and surgeons are really good at controlling local disease. So why treat, even if it was 30% of women got recurrences in their breasts who had a lumpectomy, why treat 100% of women with these aggressive therapies when only 30% would need it? 60% didn't. Save the arrow in the quiver for those who need it. All right, chances of living longer. I'll tell you what affects your length of survival. The things that suppress the immune system, major surgery. You know, big surgery will suppress your immune system. Blood transfusions, as a matter of fact, when doctors started first dealing with kidney transplants, what they discovered is those patients who had blood transfusions at the time of the kidney transplant, it suppressed their immune system. And they retained the kidneys longer. So blood transfusions, radiation, chemotherapy, lymph node irradiation, lymph node removal. These things should not be done routinely. No scientific reason to do it. Again, I just recommend a lumpectomy with clear margins. All right, how about toxic chemo regimes and estrogen suppression? Remember, this is a systemic disease. It's throughout the entire body, which, by the way, you're going to control by being a healthy person. You're going to end up living a long time. This is not gloom and doom, but you need to know so you can take proper actions. You don't want to do things that harm you just for the sake of doing things. More aggressive is not better. So doctors realized this. They realized that they were back in the late 70s. In fact, they realized it in 1951. They realized that they were dealing with a disease that had already spread throughout the rest of the body, and no local therapy would ever help as far as improving overall survival. And so we developed ways of going out and getting the cells that had spread throughout the rest of the body. And that being cancer chemotherapies, toxic cancer chemotherapies, and also estrogen suppression regimes. Okay, you can reduce overall mortality by reducing estrogens. Remember, estrogen promotes the growth of breast cancer and increases your risk of dying. Anything you could do to block the estrogens is going to make a difference in your chances of survival. You could take pills like tamoxifen or aromatase inhibitors. And by the way, I discovered a whole bunch of natural supplements that are aromatase inhibitors. And there's evidence that these work too. I never used them, but I thought I'd bring it to your attention. So these suppress the activity of estrogen on your cells. That's one way to do it. The side effects of these are you have an increased risk of uterine cancer because not only do they have an anti-estrogen effect, tamoxifen in particular, but they have an estrogen stimulating effect. So you have an increased risk of uterine cancer. You also have an increased risk of osteoporosis by taking these pills. and you go through menopause. So, you know, the hot flashes start early. There are other ways to reduce estrogen stimulation of the body and the cancer cells. And what I recommend is removal of the ovaries through a simple laparoscopy procedure. Now, I know for a lot of women, they don't want to do that and they were going to take the pills. And I think that's okay. I think it's worth your while to do. I recommend it. But if you want to get on with your life, because you're going to live a long time, that's the thing you got to start thinking is, I'm going to live a long time. And so these decisions I'm making now are going to affect me for decades. That's why you got to slow down. You can't be rushed. You've got to learn. You've got to understand what's going on so you can make the right decisions. Now, the other way that you can knock out the ovaries is by cancer chemotherapy. Cancer chemotherapy, that's how it works. Yeah, the more common cancer chemotherapies, they cause chemical castration. You know, at a price, not just a financial price, but a woman loses her hair and throws up for a year. That's cruel. Let's take a look at a review of polychemotherapy on randomized trials. And these trials show you just what I explained to you. There is a 10-year survival improvement of 7 to 11% for women under 50 who have ovary function. In other words, you deprive them of estrogens by the chemotherapy. But women who are postmenopausal, in other words, their ovaries have already shut down, you only have a 2 to 3% improvement in survival. And by the way, ladies and gentlemen, you're gonna, if you get involved in the medical business, you're gonna be fooled by a whole bunch of terminology. You know, they talk about disease-free survival. Well, you know what? If you suppress the disease, you won't see it. So you have disease-free survival. The only thing you're interested in is overall mortality. Don't put any other card. You just care about, okay, I'm going to choose this therapy over not choosing it or another therapy. How long will I live? It's the only card on the table. And so you want randomized controlled trials that look at overall survival. Nothing to brag about when it comes to toxic chemotherapy. All it does is cause chemical castration. Again, there's a much more humane way to castrate a woman. So you end up depriving the body of estrogens through various mechanisms. Now you're dealing with the fact that the bones, strength of the bones is determined by estrogens. And when you deprive the body of estrogens, you increase the risk of getting osteoporosis. So what do? Well, the basic things that you do are eat a low protein diet, because high protein causes the body to lose its bones, causes osteoporosis, particularly animal foods. And I'm talking about, you know, beef and fish and cheese. In fact, cheese is the most acidic of all foods that we eat. So you eat this acid food and the bones dissolve to release alkaline material to neutralize the acid so you don't die from all this acid you eat. And the bone material ends up in the kidney system where it forms kidney stones. And you essentially pee your bones into the toilet. So to preserve your bones, what you need to do is a low protein diet, and you know, sweet potatoes would be a great food to eat. Sunshine, very important for the health of the bones. You need to have sunshine. It's absolutely crucial. And then exercise. These are first-line therapies. Now, to preserve bone health, there are second-line therapies that I'd like you to consider. One is to take an antacid to neutralize the dietary acids you consumed in the form of beef and chicken and fish and cheese. If you take an antacid, any kind of antacid, it doesn't have to be Tums. That's calcium carbonate. It can be sodium bicarbonate. It can be potassium hydroxide. It doesn't make any difference. It's just an antacid. It neutralizes your metabolic and dietary acids at not much of a price. You know, a couple of wafers a day, 1,000 milligrams a day. That's what you do. Now, these are only, I make these recommendations only for women who have a high risk of osteoporosis. And this would be perfectly fine for a woman who had deprivation of estrogens caused by the various things that we talked about a couple of slides ago. Progesterone cream is supposed to be, well, progesterone is anti-estrogen. And there's evidence that progesterone cream causes the bones to strengthen. I don't know that it's that good of an evidence, but I don't think it does any harm. And you can buy estrogen creams over the counter in your natural food store, or it can be prescribed by your doctor. Now, if you didn't have breast cancer, I would prescribe estrogen as a skin cream. And that's discussed in the book, The McDougall Program for Women, which again is offered to you for free on our website. So I prescribe skin creams that contain estrogen and progesterone. That's the way that I deal with women who are high risk of fractures. You know, not the average person who flunks a bone mineral density test. You know, somebody who's already had some fractures due to non-traumatic events. Then I go to the next regime, like antacids and estrogens and progesterones, but not estrogens when you're dealing with breast cancer. Remember, estrogen promotes cancer. So, you know, the facts are the facts. They haven't changed in 50 years, probably 70 years. But we're still practicing archaic medicine, inhumane medicine. Of course, what do you expect from a male-dominated medical business, taking care of women? When a woman buys into the message from, you know, the standard American Cancer Society, well, they're improving, standard recommendations out there. What does she get? You know, maybe let's just give her a few extra days of life. But what does she have to do for that? She has to have annual mammograms, or maybe every 2 years. She has to do breast self-examinations, you know, maybe even daily, certainly every week. Women are frightened into doing them. She has to go into a male doctor's office. And, you know, I know there are many female doctors out there, but you know, it's usually been a male doctor's office, and take off her shirt and expose herself and let the doctor examine her. She's willing to do that for maybe a few extra days of life. She's willing to undergo biopsies, mastectomies, radiation, ovary removal, anti-estrogen drugs, and polychemotherapy. But what I hear from my colleagues and many other people is it's too much to ask them to change their diet when that's the thing that works. Ladies and gentlemen, it's the food. You know, if you want to have a good life, a long life, even when things are so desperate. I have women in my practice. The scientific literature talks about women who've had cancer spread throughout their entire body who have recovered. They've had spontaneous remissions. Don't ever give up. And the kind of diet you need to eat is the diet that is associated with the lowest chance of getting breast cancer, the lowest chance of having these poisonous chemicals in the food, the best chance of having a healthy immune system. That's a starch-based diet with the addition of fruits and vegetables. And we've been teaching that for, well, since 1977. Still teaching it today. I hope that my presentation was understandable. If not, you can read the books or you can watch the show again. But this is what I always wanted to tell you if you were my patient for breast cancer. Yeah, I want to sit down and look you right in the eye and say, this is the truth. You know, once you know the truth, then you can go out and you can make decisions. You're going to get a lot of different messages. But I would ask you to challenge your doctor. Say, hey, what about this point of view? What about this research? I've showed you the scientific studies. You know, question these people. You know, when you buy a car, you question the car salesman, don't you? You know, you're buying a type of product that will change your life. You need to ask questions, and please don't rush. This is a 10-year-old disease by the time you find it. You got days, weeks, months to understand what the truth is. And I put that all together for you in 2 books, McDougall's Medicine, A Challenging Second Opinion, and the McDougall Program for Women, which, you know, we'd like you to have. But not only we'd like you to have, we'd like to give it all your friends and relatives and your doctors and your dietitians. It's free, no gimmicks. And I've written a couple of newsletters, and the most important one is September 2017 newsletter, which talks about the fact that the treatment for breast cancer is barbaric, brutal and barbaric, but it exists. And you know what? I don't know if it's getting any better.